Get started. So my name is Austin. Today we'll be talking about the therapeutic drug monitoring of linezolid, and I would like to preface this presentation by saying this is not something that we currently do in practice, but something that I believe is coming very soon within the next 5 to 6 years. So I thought it was important to bring it to y'all's attention today and to have the discussion about it. And with that, we will get started. I have nothing to disclose in regards to this presentation. Today's objectives are to review the pharmacokinetic and pharmacodynamic properties of linezolid, to evaluate variations of PK and PD factors with the current dosing regimen, to identify patient populations that may benefit from linezolid therapeutic drug monitoring. And then lastly, we'll explain the usefulness of TDM in real-world application. So I'm going to kind of get through these background slides a little bit quickly so we can get to the meat of the presentation today. So linezolid is an oxazolidinone. It was the first in its class, and its mechanism of action is by binding the 23S rRNA of the 50S subunit, which in turn will inhibit bacterial protein synthesis. It's also a reversible monoamine oxidase inhibitor, or MAOI, and it's used in most gram-positive infections, including MRSA, and dosed at 600 milligrams every 12 hours for most indications. Whether IV or oral, it has 100% bioavailability. And the main distribution parameter that I'd like to point out, and something that I think we're all very aware of, is this drug has a very large volume of distribution at about 40 to 50 liters. Also, it's very minimally protein bound, only at about 30%. Linezolid is primarily metabolized via oxidation to two inactive metabolites, but we do see about 30% of unchanged drug in the urine, so about 30% renally excreted of the parent drug. And that brings us to our first self-assessment question, and the question being, does linezolid exhibit time-dependent or concentration-dependent antimicrobial effects? And if you were thinking time dependent, then you were absolutely correct. Linezolid is time dependent with post-antibiotic effects, which means that even after the dosing interval is up, it is still exerting some antibiotic effects against the organism that we're treating. The CLSI updated breakpoints for the drug show a susceptibility at MICs of 4 milligrams per liter or less, and resistance at 8 milligrams per liter or greater. The efficacy measurements that we know for linezolid include a 24-hour AUC to MIC ratio greater than 100, at least 80% fraction of time that the drug concentration is greater than the organism's MIC, or minimum inhibitory concentration, or trough values, or Cmin, that is greater than 2 milligrams per liter. Most of what we know about linezolid's efficacy comes from the findings of a non-comparative study published in 2003 by Rayner and colleagues that evaluated the pharmacodynamics of it in a population of patients with either multi-drug resistant infections or those that were non-responsive to conventional therapy, which was vancomycin at the time. The study showed us that the ratio of AUC to MIC was the PK/PD parameter that most closely associated with not only bacterial eradication, but clinical cure. And it also showed us that as the value of that ratio increased, we saw higher rates of bacterial eradication and clinical cure, especially around values of 100. So this slide will help solidify the feasibility of linezolid TDM as we continue to move throughout the remainder of the presentation. So first, let's take a look at the relationship between the percentage of time that the drug concentration is above the MIC and the ratio of AUC to MIC. So the results from the Rayner study that I just spoke about on the last slide show a close, somewhat linear relationship between these two variables until the value of the AUC to MIC ratio is greater than 120. And this is important because if you remember from just a few slides ago, I spoke about linezolid's efficacy being thought to be related to the 24-hour AUC to MIC greater than 100. Now let's take a look at the relationship between linezolid trough values and the 24-hour AUC. And it's shown from a 2010 observational study conducted by P and colleagues. And the study found that in patients with multi-drug resistant gram-positive infections, linezolid trough values were linearly linearly correlated to 24-hour AUC values. So when we couple these together, it's vastly important to the feasibility of Linezolid TDM, as this shows us that trough values should closely correlate with 24-hour AUC values, and this allows us to make inferences on efficacy based on trough values. So I did want to include a slide speaking about static versus cidal, because sometimes Zyvox or Linezolid gets a bad rap for being bacteriostatic. This is kind of a misleading term. These agents do actually exhibit bacterial killing. They just require higher concentrations in order to be able to do so. At the same time, Linezolid has shown to be non-inferior or superior to cidal agents such as vancomycin, Bactrim, ceftriaxone, and Dalvance across several indications. This slide is very important to remember as we continue to move throughout the presentation. So the number one Linezolid toxicity to be aware of is thrombocytopenia, which is usually defined as platelet counts less than 100. We'll talk about this specific toxicity on the coming slide a little bit in more detail, because this is the rate limiting step in the current prolonged use of Linezolid. Neuropathy and lactic acidosis are less common and usually only seen with very prolonged treatment durations. And then another major potential Linezolid toxicity or drug-drug interaction that everyone is aware of is serotonin syndrome. Although this toxicity may not be as prevalent or important as we were taught to consider it, and we'll examine why a little closer in the coming slides. So first, let's talk about the identified risk factors for the development of thrombocytopenia. The risk of Linezolid-induced thrombocytopenia is dependent on drug exposure, and this is important as we find that extended durations and elevated trough values increase patient risk for toxicity. Although the onset of thrombocytopenia may occur faster than 14 days, that treatment duration is generally thought to put a patient at increased risk for the development of the toxicity. Several studies have also shown increased odds of thrombocytopenia development in patients with trough values that are greater than 7 to 8 milligrams per liter, and trough concentrations greater than 8 have also shown to inhibit the synthesis of platelet precursor cells by 50%. So for these reasons, all of the studies that we talk about today define supertherapeutic or toxic levels of Linezolid as trough values exceeding 7 or 8. And then lastly, baseline platelet counts less than 150 have also been linked to the development of Linezolid-induced thrombocytopenia. Much like I included the slide for static versus cidal agents, I did want to take a brief moment to talk about serotonin syndrome and its relationship to Linezolid. So as I spoke about on the overview slide, Linezolid is a weak MAOI, but the risk of serotonin syndrome with this drug is very low. And we see this with a very new single center retrospective study done by Kufel and colleagues actually at the beginning of this month that was published. And they evaluated the incidence of serotonin toxicity in over 1,500 adults on Linezolid with or without serotonergic agents. They were only able to identify one patient that actually met their predefined criteria for serotonin toxicity, which is the patient had met at least 3 Sternbach criteria. So moral of the story is don't let the antidepressant scare you. It's better to utilize this drug and monitor for serotonin syndrome than to completely avoid it altogether. So to understand why this presentation today is important, I wanted to quickly highlight 2 studies. So the first by Fang and colleagues was an observational study conducted to help assess inter-individual variability in Linezolid exposure to identify the prevalence of the defined target concentration and help determine if Linezolid TDM would be useful. It was conducted in 84 adults with confirmed or suspected multi-drug resistant gram-positive infections. And the results showed that among all trough concentrations, only 57% fell within the target window of 2 to 8. As you can see from the graphic on the left, substantial variation in trough values existed throughout the studied population. The next study that I'll highlight is by Cataneo, and this study was a retrospective analysis of the first 6 years of measured Linezolid concentrations from a single center in Italy. Significant variations were seen in the 400 trough values assessed, as shown in this graphic to the right. So coupled together, these studies showed us that the generic Linezolid dosage regimen of 600 milligrams every 12 hours may not be a great regimen for all patients, and that perhaps the therapeutic drug monitoring of the drug of linezolid is needed to ensure either adequate drug concentrations or to prevent overexposure. So I wanted to take a closer look at three main patient groups, what I like to refer to as the big three, because traditionally they're patient populations that are either hard to ensure adequate drug concentrations or to limit overexposure. So we'll start with renal impairment, talk about patients with obesity, and lastly, we'll hit on critical illness. So to start with linezolid and renal impairment, we will quickly have our next self-assessment question and just kind of read the question, hold on to it because we're going to revisit it at the end of this section. So based on the following creatinine clearance cutoffs, which patient do you think is more likely to exhibit linezolid-induced thrombocytopenia? The patient with a creatinine clearance of 82, 33, or 64. So I wanted to start this section by talking about the study that led to the recommendation of no renal dose adjustments for linezolid. This was an open label parallel group study conducted in 2003 by Breyer and colleagues, in which they looked at healthy patients with a wide range of renal function from normal to end-stage renal disease, and they gave them one single dose of oral linezolid. And as you can see on the slide there, they broke up the patients into 4 different groups based on their creatinine clearance. All groups assessed showed similar AUC values of linezolid, although they did show increased variability as patients declined in renal function. And dialysis improved the PK profile of linezolid in patients with ESRD. It removed about a third of the dose and decreased AUC by about 50%. Ultimately, they didn't see a correlation between decreased creatinine clearance and decreased linezolid clearance. And so it was their recommendation to not have a renal dose adjustment for linezolid. And that is how we have our current practice now. However, upon further review, post-marketing studies showed different findings than that of Breyer and colleagues. In 2006, there were actually 2 separate studies that were published evaluating the efficacy and tolerability of linezolid in patients with renal dysfunction. So the top chart represents findings from a retrospective case control study by Lin and colleagues, in which they evaluated patients with and without renal dysfunction, which they defined as a serum creatinine of 1.3 or higher in women and 1.5 or higher in men. And while they didn't find that clinical efficacy differed between the 2 patient groups, they did see that patients exhibiting renal dysfunction had a greater chance of developing thrombocytopenia, which they defined as a platelet count of less than 100. Interestingly, patients with renal dysfunction had a longer mean time to thrombocytopenia development, about 15 days versus 12. And patients in both groups had similar recovery times of about 4 days. So Wu and colleagues, looking at the chart on the bottom of the screen, conducted a retrospective case control study evaluating patients with non-end-stage renal disease and those with end-stage renal disease on hemodialysis. They found that even among patients with renal dysfunction at baseline, being on hemodialysis increased a patient's risk of thrombocytopenia. They also found that patients with end-stage renal disease had a higher rate of anemia development than their counterparts. And while not statistically significant, the time to thrombocytopenia development was shorter in patients with or on dialysis, with a mean duration of 10.4 days versus 13 days. So to better understand the influences of linezolid concentrations on hematological toxicity, Nikui and colleagues conducted an observational study of adults on linezolid at a single center in Japan. The authors of this study defined thrombocytopenia a little bit differently than the previous, with their definition being a 75% decrease or more from baseline platelet values. For measurement of linezolid concentrations, they assessed trough values at days 3, 7, and 14 of treatment. And of the 30 patients that they assessed, 17 developed thrombocytopenia. And when we look at these 17 cases, it was found that platelet decrease was more common in patients with high linezolid trough values and those with a baseline creatinine clearance of less than 60. So if we look at the box and whisker plot on the left and the table at the bottom, we can see that patients with renal impairment again defined as creatinine clearance less than 60, were found to have a significantly higher trough value and frequency of toxicity development. So if we look at the box and whisker on the right-hand side, we can see that the relationship between linezolid trough concentration and incidence of thrombocytopenia development were associated with elevated trough values. In fact, this study found that a linezolid trough value of greater than 7.5 at day 3 was associated with a statistically significant increase in the risk of toxicity development. So if we think back about the slide where we talked about the risk factors for the development, this study kind of helped bring that to light, as well as some other literature that we will talk about throughout the remainder of the presentation. So just in case you aren't convinced yet, let's take a look at one additional study evaluating the link between renal impairment and increased risk of linezolid-induced thrombocytopenia. So this study was published in 2019 by Krauss and colleagues, and it was a retrospective analysis of real-world data from routine therapeutic drug monitoring to again assess the relationship between renal impairment and thrombocytopenia and the impact of renal function on the drug's clearance. Again, the study found similar results as previous literature discussed, with renal impairment being associated with increased risk of thrombocytopenia development. And they also found that low baseline platelet counts and high baseline total bilirubin levels were also independently associated with the toxicity. The study also conducted a Monte Carlo simulation. And while they assessed several different dosing schemes, I wanted to point out their findings based on the conventional dosing of linezolid at 600 milligrams every 12 hours. As you can see on the slide, based on their simulation, trough values associated with toxicity were estimated to occur in over half of patients with a creatinine clearance of less than 60. Interestingly, the simulation found that perhaps a dose reduction of half of what we would normally give patients to 300 milligrams every 12 hours would be the best balance of safety and efficacy in this patient population. So now let's talk about some possible adjustments to linezolid dosing that could decrease the potential risk for the toxicity of thrombocytopenia development in these patients with renal impairment. This was a single center retrospective study done in Japan. It was published in 2021, and it included patients who were at least 13 years old. They had a documented or suspected gram-positive infection and at least one steady state linezolid trough value. Their aim was to evaluate the relationship between renal impairment, thrombocytopenia, and drug overexposure, as well as to evaluate the usefulness of therapeutic drug monitoring and guided dose adjustment to help prevent and or recover from thrombocytopenia and prevent treatment failure. So they looked at patients first by their creatinine clearance cutoffs and stratified them by either having renal impairment or no renal impairment. And then they looked at them whether or not they received therapeutic drug monitoring as well. Of note, this study did exclude patients on renal replacement therapy or those with tuberculosis or non-tuberculosis mycobacterium infections. When looking at thrombocytopenia occurrence, again, we're shown that this occurs at a significantly higher rate in patients with renal impairment, and the study found a p-value of 0.002 for this outcome. The results also showed a similar time to development as previous literature, and once again, that renal impairment is an independent predictor of elevated linezolid trough values at steady state. When comparing the two groups in instances of needing dose adjustment based on therapeutic drug monitoring assessment, it's no surprise to see that patients with renal impairment required significantly more dose adjustments to avoid linezolid overexposure. So that leads us into the discussion for the usefulness of therapeutic drug monitoring in the renally impaired population, which this study also shed light on. So first, I want to draw your attention to the top row of the chart. So when we look at patients with renal impairment who received TDM, we can say a much longer duration of therapy, which is important because this is currently the rate limiting step in allowing us to use linezolid for complicated infections. While patients with impaired renal function still experience higher rates of thrombocytopenia, the rate of treatment failure due to hematological toxicity was significantly lower in the TDM group, with a trend to significance in recovery. And patients with normal renal function also showed similar findings. However, the rates of recovery and treatment failure were not significantly different between the two patient groups. So just to wrap up our renal impairment section, renal impairment increases the risk of thrombocytopenia development during linezolid treatment, and this risk may be further accentuated in patients with end-stage renal disease. And a dose reduction or drug monitoring may be needed to safely administer linezolid to this patient population. So revisiting our second self-assessment, based on the following creatinine clearance cutoffs, which patient do you think is more likely to exhibit linezolid-induced thrombocytopenia? Perfect. Okay, now we're going to shift gears and talk about linezolid and obesity and how these patients have variations in drug concentrations, leaning more towards underexposure than we just talked about in patients with renal impairment. So first, let's take a look at a study conducted by Cojudi and colleagues at a single center in Italy that had an established linezolid therapeutic drug monitoring service. They evaluated adults at various BMI categories, and their goal was to assess the population pharmacokinetics and identify covariates altering linezolid disposition. The BMI cutoffs that you see there are pretty standard, and then they also assess patients as far as their renal function based on their creatinine clearance. The authors utilized a Monte Carlo simulation to estimate the probability of target attainment, which is basically can the dose get to the efficacy endpoints that we had talked about earlier. And they defined those target concentrations as a trough of 2 to 7 or a 24-hour AUC to MIC of greater than 100. The regimens that they assessed in the simulation were 450 and 600 milligrams every 12 hours and 450 and 600 milligrams every 8 hours. A minimum rate of 80% probability of target attainment was set for the assessed doses. And it is important to note that for this study, the creatinine clearance was calculated using the chronic kidney diseases epidemiological formula. So of the 112 patients included, a total of 645 concentrations were analyzed. And from the results, we can see that standard dosing of linezolid may lead to underexposure in a large percentage of overweight and obese patients, with nearly 40% of patients having subtherapeutic trough values. For patients with renal impairment, the standard dosing of 600 milligrams every 12 hours was the max permissible dose seen in their Monte Carlo simulation due to higher rates of theoretical toxicity, which they defined as trough values exceeding 8.06. Next, I wanted to highlight a study by Z and colleagues in which they evaluated the effect of obesity on linezolid pharmacokinetics, the probability of target attainment for MRSA pneumonia, and the time course of target attainment. This was a multi-center open label study conducted in Greece that included 15 critically ill adult patients with BMIs of 35 or greater to conduct a Monte Carlo simulation on the probability of achieving 100% time of drug concentration over an organism's MIC for the standard dosing of linezolid at 600 milligrams every 12 hours over the course of 3 days. So when we look at the visual, on the top, we can see that as a patient's weight increased, there was a lower probability of attaining the goal time of the drug concentration greater than the MIC. And this was assessed for 4 different MIC values at 0.5, 1, 2, and 4. And note, to do this, they used a static age of 60 years in order to run this simulation. The visual on the bottom shows the probability of target attainment for the same MIC values of 0.5, 1, 2, and 4, but at increasing patient years of age. And so as the patient aged, the probability of target attainment increased. And I think for this one, it's important to note that for this simulation, they used a static weight of 125 kilos in order to run this evaluation. So now that we've seen the potential issues related to obesity in the current linezolid dosing regimen, let's evaluate the variations of it within the population. So this single center prospective open label study by Velody and colleagues evaluated linezolid pharmacokinetics between adult patients who were moderately obese, which they defined as a BMI of 30 to 39, and those with morbid obesity, which was a BMI of 40 or greater. Please excuse my non-linear red line. So while the study did not show a statistical difference in the 12-hour AUC between the two groups, we are able to see that even within a population of obese patients, linezolid concentration is extremely variable. And if we think about the linezolid breakpoints of 2 milligrams per liter, 7 out of the 20 patients would have had suboptimal levels. And if we think about an MIC of 4, only 1, which the study considered as an outlier, would have had adequate drug concentrations. So that point brings us back to the Cojudy study that we discussed earlier. In order to better assess linezolid efficacy in obese patients, they utilized the results of their Monte Carlo simulation to allow comparison of estimated probability of target attainment versus MIC for common gram-positive organisms to produce an estimated cumulative fraction of response. And when looking at the low dose of 450 milligrams every 12 hours, only coagulase negative staph species or staph epi for a common organism would be inhibited, and this dose might not be viable in patients with high renal function, as you can see at the very bottom of the first row. When we look at the conventional dosing of linezolid at 600 milligrams every 12 hours, we can see that for Staph aureus, this may be an effective dose unless the patient has high renal function. But for cases of intercoccal infection, this dosage regimen may only be effective for those with renal impairment. So to summarize our obesity section, obese patients may exhibit lower probability of target attainment when we consider the standard linezolid dose of 600 milligrams every 12 hours. Variations exist for the linezolid pharmacokinetics within the obese population, and it's important to remember to continue to assess patients' renal function and organism MICs when considering linezolid in this population. It's also, despite a potential chance for increased underexposure in this population, patients with obesity and renal impairment may still be at risk for the development of linezolid-induced thrombocytopenia. So always important to consider a patient's renal function outside of their weight category. So the last big section that we'll talk about today is linezolid use in critical illness. And that brings us to our next self-assessment. And the question is, for which patient would you advocate linezolid therapeutic drug monitoring for? Patient 1 with ARDS and a creatinine clearance of 85. Patient 2 with septic shock and a lactate of 7. Patient 3 with a baseline platelet count of 100 and a creatinine clearance of 30. So again, just kind of hold on to it and we'll reassess once we get to the end of this section. So the first study that we'll talk about here is a small single center study out of China in which they evaluated 8 critically ill adults treated with linezolid. Based on the results of the study, we can see a wide variation in the pharmacokinetic, pharmacodynamic parameters of linezolid, which you can see as the wide range of AUC to MIC values, as well as the wide range of time greater than MIC. 3 of the patients failed to reach adequate levels of exposure, which the authors for this study defined as a percentage of time that the drug concentrations were greater than the MIC of at least 85%, and AUC to MIC ratio values of 80 to 120. And it's worth noting that these 3 patients exhibited higher drug clearance than the rest of the cohort. Failure of clinical cure was seen in 2 out of these 3 patients with underexposure. So to get a better idea of the extent of the linezolid concentration variation in the critically ill population, I want to take some time to talk about the study published by Zoller and colleagues in 2014. This single center observational study evaluated 30 critically ill adult patients from 2 ICUs at a hospital in Munich, and they were given standard doses of linezolid at 600 milligrams every 12 hours. The study set target concentration as 24-hour AUC values greater than 200, which you would expect an AUC-MIC ratio of 100 with a MICs of 2, and trough values of greater than 2 milligrams per liter. They also set toxicity thresholds as trough values exceeding 10 milligrams per liter and 24-hour AUC values exceeding 400. So contrary to other studies that we've looked at to this point, this study included patients on renal replacement and therapy and those on ECMO, with 5 of the 30 patients that they assessed being on CRRT and 7 being on ECMO. Much like the previous study, this one found that critically ill patients exhibit high interpatient variability in regards to linezolid PK/PD parameters. And the results of the study also show high intrapatient variability, with 9 patients having a max trough value that was 5-fold higher than their minimum values. In regards to patients on ECMO, these patients exhibited high rates of underexposure, with 5 of the 7 patients that they included having 24-hour AUC values less than 200 and trough values less than 2. But patients on CRRT were seen to have significantly higher trough values as well as AUC values. So to get a clear understanding of what could be driving the variation in this population, Talbert and colleagues took the same study population as the previous study, along with 22 other critically ill patients, and examined the data for covariates of linezolid pharmacokinetics. And for their efficacy surrogate, they chose a 12-hour AUC value of 100, or greater than 100. They found that elevated creatinine clearance, elevated weight and height, increased fibrinogen, antithrombin, or CRP levels, as well as the presence of ARDS, correlated with a decreased AUC, decreased 12-hour AUC, while lactate levels, elevated lactate levels and low creatinine clearance correlated with increased linezolid concentrations. Notably, in their pharmacokinetic simulation of the independent patient group that they assessed outside of the critically ill patient population that they looked at, when assessing the presence of ARDS, only 6% of an independent group actually achieved their efficacy surrogate of the 12-hour AUC value of greater than 100. In a follow-up study, the same authors set out to evaluate if a change from the current linezolid dosing regimen could optimize therapy in the previously identified population of critically ill patients. They evaluated linezolid dosing regimens of 1,200 to 3,600 milligrams per day via Monte Carlo simulation. And for efficacy surrogates, they chose an AUC to MIC ratio of 100 or more, and fraction of the time over the 24 hours that the drug concentrations were greater than the organism's MIC. And they evaluated doses for their ability to obtain these surrogates and at least 90% of the assessments with a related toxicity rate being no more than 10%. So that was they wanted the dose to at least have 90% ability to achieve target concentrations and only put patients at no more than 10% risk of toxicity development. So looking at the top graphic, we can see that based on the results of the Monte Carlo simulation, the current dosing regimen of linezolid is unable to obtain optimal concentrations for staph and Enterococcus species, in which those were the 2 lines on the chart there represent, with the first one being staph and the one below it being Enterococcus. And in fact, every 12-hour dosing regimens with total daily doses up to 3,600 milligrams were found to not provide adequate fraction of time that drug concentrations were greater than the MIC of these organisms. When we look at the bottom graphic, for the probability of target attainment for ranges of MICs of 0.5, 1, 2, and 4, we again see that the current linezolid dosing regimen may not provide adequate drug concentrations for even MICs of 0.5. Because of the high influence of the presence of ARDS on linezolid underexposure, the authors of this study also conducted a subgroup analysis that evaluated dosing regimens for patients with and without ARDS. They found that for patients with ARDS, doses obtaining the target AUC to MIC values with continuous infusion were over toxic thresholds for 22 to 26% of patients, and they were unable to identify a dose that really worked to fit the 90% target attainment and no more than 10% toxicity development. 2,400 milligrams every 6 hours was able to obtain at least 80% target attainment and to minimize toxicity. So maybe a useful dose there. But for patients without ARDS, The doses that obtained the target AUC to MIC ratio with continuous infusions were over toxic thresholds for 28% of patients. Again, they were not able to identify a dose. However, when we look at 1,400 milligrams every 6 hours, they were able to obtain at least 90% of the fraction of time over the MIC and to minimize toxicity. The results of this study show us that simply adjusting the daily dose of linezolid or the manner in which it is administered may help with target attainment, but may not be feasible in their relations to or in their propensity to cause toxicity. So next, I wanted to talk about CRRT in linezolid because the pharmacokinetic properties of linezolid could allow for the altered clearance of it via renal replacement therapy. Because the drug has a low molecular weight, like we talked about very early in the presentation, it's about 30% protein bound, and it has a very high volume of distribution. CRRT modality, dose, and membrane type could allow for variations in linezolid's clearance. And then lastly, in current practice, there is no recommendation of dose adjustment for the drug and for patients on CRRT. So to evaluate the potential effects of CRRT on linezolid PK/PD, Ide and colleagues conducted a single-center prospective study of 27 critically ill adult patients with sepsis or septic shock, and they compared the linezolid parameters in patients without renal dysfunction to those with and those undergoing low-dose CRRT. They define renal impairment as a creatinine clearance of less than 50, and patients on CRRT underwent either CVVHD or CVVHDF with a median dose of 14.2 milliliters per kilo per hour. Their defined target concentrations for efficacy were an AUC to MIC ratio of 80 or more, and a fraction of time that the drug concentration was greater than the MIC of 100%. When looking at the achievement rates for the concentration parameters, the results showed that patients with sepsis and septic shock and preserved renal function had low rates of target attainment, even for MIC values of 1. However, for patients with impaired renal function and those on CRRT, they had higher rates of success in reaching the defined concentration targets. Notably, patients on CRRT had significantly higher lactate levels than those with preserved renal function, which again was an identified covariate in the previous study that we looked at by Talbert and colleagues. So we've talked a lot about the potential risk of linezolid underexposure in critically ill patients, but if you'll remember from the first 2 studies that we discussed in this section, an extremely wide variation of pharmacokinetics exists in this population, and overexposure could occur as well. So in 2019, Kim and colleagues conducted a single-center retrospective exploratory analysis of 60 critically ill adult patients without severe thrombocytopenia prior to therapy, which they defined as a platelet count of 50 or less. And they defined thrombocytopenia as platelet counts less than 150 or a 25% decrease from baseline. Nearly half of all patients develop thrombocytopenia with malignancy and serum creatinine of at least 1.5 being associated with increased risk. Most patients who developed thrombocytopenia were characterized as having moderate severity, and based on the results from the Naranjo algorithm that they applied to help rule out other potential causes of thrombocytopenia development, the study found a predominantly probable relationship between linezolid and thrombocytopenia. None of the cases were found to definitively be caused by linezolid exposure. When the authors compared patients with and without thrombocytopenia development, they did see a significant difference between the groups in regards to platelet transfusions as well as ICU mortality. So to wrap up this section, linezolid PK and PD vary substantially in the critically ill. Potential for non-target attainment exists in this population, which may be extenuated by presence of ARDS. CRRT does not seem to lower probability of target attainment despite favorable pharmacokinetic properties for linezolid removal. And linezolid-induced thrombocytopenia may still occur, and if so, it may increase ICU mortality. So let's revisit our third self-assessment question. And the question again is, for which patient would you advocate linezolid TDM for? Patient 1 with presence of ARDS and a creatinine clearance of 85, patient 2 with septic shock and a lactate of 7, or patient 3 with a baseline platelet count of 100 and a creatinine clearance of 30. So this one's kind of a trick question. So it would be all of the above. So that's all great and grand, but is TDM actually useful? So does it actually work in practice? So now we'll talk about two studies really quickly that show that linezolid therapeutic drug monitoring might actually help us use this drug in more complicated infections and allow us to use it longer. So this study was, again, you'll hear these names pop up again and again because very similar groups of folks are evaluating this. So Kajudi and colleagues conducted a single center prospective open label study, including 61 adult patients with multi-drug resistant gram-positive infections that needed treatment for longer than 10 days. Each patient was started on the standard dose of linezolid at 600 milligrams every 12 hours and adjusted based on trough values at day 3 to 5, and then once weekly thereafter. Target trough concentrations were set at 2 to 8 milligrams per liter, and thrombocytopenia was defined as platelet counts less than 112.5, or again, a 25% decrease for those with platelet counts at baseline of 75 to 149. The results of this study showed that patients responding to dose adjustments made via therapeutic drug monitoring had significantly longer durations of treatment. And of the 33 patients with linezolid overexposure, mean trough values exceeding 8, only 4 were unable to enjoy stable attainment of the target trough range when utilizing therapeutic drug monitoring. 9 patients in total developed thrombocytopenia, 3 in each group. And notably, only the patients in the therapeutic group and transient overexposure group recovered from thrombocytopenia without the need for therapy discontinuation. The Limit 1 trial was actually just published in March of this year to evaluate the Linezolid toxicity and clinical management. This was a multi-center retrospective study set in Australia that evaluated 622 patients receiving linezolid for more than 5 days. The target range for this study was defined as trough value of 2 to 7 milligrams per liter. And as expected, patients who experienced toxicity had higher baseline serum creatinine and lower baseline platelet counts, as well as longer durations of therapy. Now, when we look at factors associated with linezolid toxicity in the study, the results showed that appropriate linezolid dose adjustment with the first therapeutic drug monitoring significantly decreased odds of toxicity with an adjusted odds ratio of 0.45. So the authors concluded that the increased odds ratio seen with any linezolid therapeutic drug monitoring suggests that drug concentrations were obtained more frequently in patients experiencing toxicity. So for our last self-assessment, which patient is most likely to develop toxicity related to linezolid therapy? Would it be patient 1 being treated for 10 days and a trough value of 9 at steady state, patient 2 being treated for 10 days and a trough value of 5 at steady state, or patient 3 being treated for 14 with a trough value of 4 at steady state? If you said patient 1, you're absolutely correct. So final conclusions, a wide interpatient variability exists in linezolid pharmacokinetics and pharmacodynamics. Few standard dose adjustments obtain target concentrations without increasing a patient's risk for toxicity development, and therapeutic drug monitoring of linezolid should be considered at least in order to ensure target concentrations and minimize risk of adverse events with its use. And with that, I will open it up to any questions.
They've been on it together, all of a sudden, oh my gosh, my patient has serotonin syndrome. So is there something like one patient actually all serotonin?
100%. Sure, with the right direction. I'd be happy to. I don't think that the risk does not outweigh the benefit. So to withhold linezolid for someone who is on another serotonergic agent doesn't make a whole lot of sense to me, because you can monitor for the development of serotonin syndrome and stop linezolid if you need to and swap to a different antibiotic at that time. But I don't think the risk of the development of the syndrome is high enough to warrant just completely avoiding the drug from the get-go. Sure.
So you presented a lot of data, a lot of studies that we obviously don't have the ability to monitor. So in what patient, what population are you from standard?
So I think, are you asking, who would I utilize the therapeutic drug monitoring in?
That's really where we are right now, right?
I would, basically, without the therapeutic drug monitoring in patients who would be at higher risk for the development of thrombocytopenia, I would avoid linezolid altogether. So someone who has end-stage renal disease on dialysis, I would choose other agents such as vanc, when you can, easily give them the same therapeutic coverage as you would with linezolid. If I was going to use linezolid in someone with renal impairment, I would possibly cut the dose in half, so do 300 milligrams Q12, based on the results of those Monte Carlo simulations. I think that it provides enough target concentrations and it minimizes toxicity in order to safely be used. Of course, if patients have kind of rebound renal function, once they get in the hospital, get adequately resuscitated with fluids, then you can consider going back to the 600 milligrams Q12. But I do feel comfortable with the 300 in a patient that we were kind of only sold on using linezolid for. But as far as a dosing difference or using a different dose right now, I would feel more comfortable with using a different agent until we had the availability for the therapeutic drug monitoring.
I have a question, a thought kind of attached to the answer to that previous question. So, a lot of times we're using this drug empirically because patients have high risk of renal toxicity with vancomycin, right? So kind of thinking of empiric options for these, MRSA being one or the other. So when answering Bree's question, are you thinking about patients and recommending to acutely reduce the dose in patients who may only be on an empiric course for less than 5 days? Or would you wait until it was determined that a patient was going to require a prolonged course of therapy at which the risk for onset of thrombocytopenia increase? And then secondly, what is the severity of the outcome of that adverse effect, right? So if you notice the decrease in platelet count, is this something that's worth the avoidance of the renal risk with vancomycin to be able to discontinue that Zyvox when you see that adverse effect onset and just switch to something else at that time? That's a long question, sorry.
No, I think so. You make a good point as far as the first part of it. Could you actually
so are you saying that we should empirically reduce the dose if we aren't really sure that the patient's going to be on the drug for more than 5 to 7 days and they have renal dysfunction?
No, I think that makes a good point. So, or you make a good point there. So if you're empirically using it and plan to de-escalate and not planning to use it long term, I think it would still be fine to use the 600 milligrams Q12 in those patients, just because you're not going to use it long enough for it to theoretically have the toxicity development in those patients, even with renal impairment.
And then the second part of that is how do you contrast the seriousness of the detrimental adverse effects of vancomycin on renal impairment versus the severity of causing thrombocytopenia that can be recognized early with Zyvox or Linezolid, does that reverse quickly, or which of those would you say is the riskier scenario?
I don't have the answer to that question right offhand. I can look into the time frame for reversibility of thrombocytopenia with Linezolid and get back to you.
I get asked that a lot on medicine service. We'll see thrombocytopenia in a patient who's been on Zyvox with some of these risk factors, 5-7 days, and they want to know, should I stop it? And 2, when can I expect that to resolve? So that's just something I don't know the answer to either.
About different indications for the dosing without therapeutic drug monitoring, recommend that we evaluate patients here. And the second part of that, is there
No, there's not. It's only currently available in the 600. So I would not, again, kind of ties back into the empirical use of Linezolid. So I would not favor going to 450 milligrams Q8. Just based on empirically using the drug, I would more favor it in patients that if we had the availability to do Linezolid therapeutic drug monitoring, and we were expecting to use this drug, long-term for maybe an obese patient in order to adequately ensure that we're getting target concentrations. So if we had therapeutic drug monitoring and we were thinking that we might use Linezolid long-term for an obese patient, I think that would be appropriate at that time because we could readily measure and safely assess whether or not we're putting a patient at risk for overexposure.